here.
Hi, welcome to Doc Talks. I'm Dr. K.
And I'm Dr. Booth.
Today we are talking about shoulder separations. Now, what does that mean? It's different than a shoulder dislocation. A shoulder separation involves your clavicle and your scapula. It starts at something called your acromioclavicular joint, or something that we call AC joint, and sometimes you might hear it called an AC separation. But what is that? So what happens is that you have a very strong, thick ligament that holds the top of that shoulder blade to your collarbone, and sometimes with injury, impact, stresses and strains, just like any other ligament in your body, it can get pulled, stressed, and
Bike crashes,
sprained.
can it happen in those?
Yeah, bike crashes, which Dr. Booth knows all about, and which is why we are also highlighting it this week. But after we figure out, okay, we have a shoulder separation going on, we need to make sure, hey, is this going to be a surgical case or is it non-surgical? So Dr. Booth, he had a nice little crash on his mountain bike. He came in, and that was the first thing we were checking out. So we said, what do we need to look for? I asked, hey, Dr. Booth, do you have any tingling or numbness down into your hands at all?
Nope.
Nope. Awesome. Clear.
Check number
Sweet.
one.
The next thing is sometimes we'll expose the shoulder itself and look for something called a step defect. So this is right where your AC joint is located, and when that ligament gets sprained, sometimes we see a nice little step down, and we said, nope.
None of that either.
Checked off the list. Then I simply ask, hey, are you having any big shifting, any big clunking, anything like that?
Nope, still nothing.
Awesome, we're doing great. And then we say, hey, has there been any significant swelling or bruising?
Nope.
We didn't see anything around the area. And then another very important question we have to ask, hey, do you have any pain just sitting there or with breathing? Does that hurt at all?
Yep, none of those things. So that was really good for me because it was an excruciating pain the night of. So I didn't know exactly if I was going to seek out any more medical imaging or anything, but I knew in my mind in the beginning of the acute phases of pain, it could be like a very, very high amount of pain. Dr. B also experienced a clavicle fracture, and she knows how painful it can be, especially kind of around these areas, very, very sensitive, lots of nerves. Really close to the neck, which means your body will have a little bit more heightened response. Mm-hmm. So with that stuff, we always got to make sure that we check the boxes off, and she did that. We went through kind of our checks and balances on if I needed to get more medical imaging or not. Thankfully, I didn't, but these things usually don't happen also in isolation. So there can be other tendons, the capsule around the shoulder can be irritated. So that stuff also had to be evaluated. A really good orthopedic examination was needed. So we went through and we made sure we cleared some of those boxes off too. There wasn't anything that was, oh my gosh, we need to go send this to emergency services or anything like that. So that was good. But then, where do we start, with something like this? Because if it is a non-surgical case, that means that you start out in a physical therapy or a chiropractic clinic where they can start figuring out your pathway to getting it strong, getting your range of motion back. Very important that we do get our acute phases, we make sure that we let the tissue desensitize. So things that can really help at that time are what are all those?
Yeah, that's going to be kind of your simple rest, trying not to do a lot of big movements that continue to aggravate everything. And then two, your anti-inflammatory style medications just to help give a little bit of relief to yourself, but also to help bring down some of that inflammation. So that truly is sometimes some of the first steps that we take when we know, like, hey, we're not surgical, but we do need to give your body a little bit of time to rest and just kind of desensitize. Everything is kind of like, ouch, 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 everything's hurting. And we went through a time where, we just really had to kind of figure out what tissues are actually injured, because your body is getting all these pain signals where it's like everything is hurting, every movement is hurting, even though not necessarily every single tissue involved in that shoulder is injured. So simply resting it, self-ice if you can handle the pressure, certainly is an option as well. But yes, resting, anti-inflammatories, just kind of helping to desensitize bring down some inflammation, and then from there we can move forward.
Yeah, this was the first one. First day through about the third day is how I was treating what Dr. B was saying. It was really excruciating. The first night it got progressively better. Third day, that's when I got more into trying to start regaining some range of motion. That's the first goal. We want to see if we can start regaining range of motion. So over the first couple of days, like I said, anti-inflammatories, I braced, kind of had my hand across my body. If you have ever been hurt in the past, most of the time our body goes into what's called fetal position to protect itself. You try to get your body as close to itself as you can, and you just try to hold on to it. That's basically what our body does. After that, you have to start regaining those ranges of motion. So passive first. My go-to movement was trying to get my hand kind of up over my head, but I didn't want it to do this. I didn't want to use my muscles to get this to happen. So I did this in the shower. I did this slowly against couches and walls, but I placed my hand on something that was fixed. So if I was here and in pain and I couldn't go up over my head, I placed my hand on something that was fixed. And then I slowly started walking myself back to where my arms didn't have to do anything, my hips or my shoulders didn't have to do anything, and I was able to get my arms slowly to an overhead position. As I got better with that, I started to raise a little bit, get a little bit of muscle activation, and hold myself in that position. So my arm had to start stabilizing those things. And that the beginning portion of that is passive. I want to be as just getting my joints to start feeling movement again, not active. I'm not pulling myself in those positions. I'm not using my muscles to get myself there. Mm-hmm. Then I get into active. So actively treating something. We always look at movement as our objective measure for treatment. We don't want to treat just a medical diagnosis. If I just treated a disc herniation or AC separation and I went through a protocol, that's not going to help the patient get to back on the bike or back into running or back into lifting. We want to treat the movement. So for me, getting up over my head, stabilizing, holding onto handlebars, that's pretty important for me. That's when I started getting into plank variations where I'm putting myself down to a plank, whether it was on my knees in the beginning, or now I'm getting into being able to do it on my toes, getting into a side plank variation where my shoulder has to stabilize. That becomes more of an active stabilization. So I've gained my range of motion. I've started going through active stabilization of my shoulder. Now I'm going to have to start moving into more of a strength phase. So being able to press something up over my head, being able to do stuff at a slow pace, very low, humbled weights in the very beginning. It's going to suck, I know it is, but at the same time, I know the steps have to be taken because I did have a pretty significant tissue damage. So next step, whenever I start figuring out what my rehab plan is going to look like with a strength component to it, it's going to probably have some pressing, either a vertical or a horizontal plane, so vertical going up over our head or having a press going out in front. Those are going to be some of the variations that I'm going to start introducing. But definitely make sure if you have a trauma to the shoulder, you slip, you fall, you put your hand out and you have some pains in the shoulder, make sure someone checks out the red flags. No fractures, no step deformities, no bruising, swelling, clunking, clicking, instabilities, and then figure out if it's a surgical versus non-surgical case. And then if you need someone that's going to be your non-surgical treatment guide, that's going to be us. Make sure you reach out to us at 702-558-2151, and we'll get you guys taken care of, your guide for getting you back from a shoulder separation. If you guys have any questions, you can always reach out and we can get you into a strategy session just to kind of talk about the potential help, or maybe we even see if you need imaging or send you somewhere else in case there is a red flag that kind of scares us and say, hey, you need to go get this checked out. So if you guys have any questions, reach out. Until next time, we'll see you at Doc Talks next Wednesday. See ya.